done that? Oh yeah, okay. So recording has started, lovely. Okay, so I'd just like to welcome everyone to this session that's been set up today for community leaders and health champions to be able to talk directly with the specialists that we are blessed with in our local authority, who are the public health specialists who focus on population health challenges. And obviously, like I've just said about digital, when we look at population health challenges from the sky down, the helicopter view, it's a different perspective from the ground up. And so public health traditionally looks at things from more helicopter view, and our colleagues can challenge me on that. Our colleagues in the local authority's public health department are focused on the helicopter view in Enfield. But this is a really good opportunity today to hear about what the priorities are for the local authority's public health team, and there are considerable challenges, and then hear from those of us on the call who would be what we would call specialists about within our communities. We can listen to hear what you've got to say about what the priorities are that are emerging for you and your service users. So I am recording this session because we will share it with people who couldn't attend, and I ought to introduce myself, I suppose. That would be a good start. I'm Helen Price. I work for Enfield Voluntary Action. My colleague Joe is on the call today. We are happy to welcome Mark and Debbie-Ann from the local authorities public health team. And the format for today is that I will hand over to them and they can share their screens as necessary with you. Oh, poor Bernie, he's having difficulty getting in and out. I
think Ginny's having problems as well, actually. Quite sure.
Right. Okay.
Anyway,
well, I'll leave you to sort that out, Joe, because the link is on my out of office, so anybody that does email me will get the link, and I have tested it this morning, so I know it works. Welcome to those who have just joined. We've sort of done the introductions, and I just wanted to hand over to Mark and Debbie now from Public Health. I think once Mark and Debbie have spoken, it'd be good then to do just a quick introduction of who the other people on the call are before we open it up to questions. So, and as I say, this session is all about the participants on it. I haven't got any particular agenda about how it should continue. We've already learnt some information about digital difficulties, which is, and anybody that else that's had any challenges, please do let me know, because it's really important that we learn from that. Right, over to yourselves, Mark and Debbie. You are the dream team, the duoing today. I'll leave it over to you.
Just introduce myself first. I'm Mark Tickner. My formal title is Senior Public Health Strategist at London Borough of Enfield. I have 4 current roles, which is common about most of our public health team at Enfield. We have a number of roles. My first role is helping to manage the Health and Wellbeing Board. My second role is the Mental Health Lead in Public Health. My third role is the Learning Difficulties Lead in Public Health. And a fourth role I acquired about 2.5 years ago for some reason was the Infection Control Lead in Public Health. All of which feeds into my work. Just very quickly, I'll introduce Debbie-Ann, my colleague.
Hi everyone, my name is Debbie-Ann Ofosuware, and I'm a public health practitioner, and like Mark, my role does entail quite a few different roles, including making every contact count, our organizational health and wellbeing lead, and also I have been doing some work on social prescribing, as well as NHS health checks as well.
Okay, and Debbie-Ann has stepped in at very short notice for my colleague Louisa Bourlay, who unfortunately has come down with influenza this morning. And yes, she was vaccinated. Right. We have some quick slides to go through, which I think kind of illustrates the sort of the helicopter view we were asked about earlier on. Of course, nowadays it's all drone views, I think. But I mean, I can just share my screen quickly. Can you see a screen? The screen?
Yes, I can. Can
Yeah.
everybody
Right,
else? Yeah.
Yes, I
Right.
can.
Yes.
Okay.
Yeah.
Right. Okay. So essentially, we're going to do a quick sort of overview of the significant challenges that we are dealing with in Enfield, and I think none of these are a particular surprise, but there's some more granulated information that's come out recently, which is quite concerning as well. And at the end of this, we'll obviously go into the Q&A, and there's a few other things we haven't mentioned in here, but I think that there are things we do need to discuss a bit as well. Okay, if I can get the thing to work. Right, so this is a very familiar picture you'll see, which is inequalities in Enfield. The most deprived wards in the borough are to the east of the borough, and this line is almost specifically defined by the A10. And one of the things that I noticed when I first came to work in the borough, which was in October of 2013, 9 years ago now, was this. I could see it on the information I was given then. I could see it by simply walking around the borough as I was asked to do. And I don't think it's changed particularly. This is fairly recent information, 2019. It was obviously before the pandemic. I don't think the pandemic has shifted that particularly. If it has, it's probably made it go slightly worse. And wherever you have inequalities in terms of social or economic inequalities, you will see health inequalities as well. And we have a couple more maps which sort of beautifully illustrate that. I mean, this is the health inequality in Enfield, the obesity map. We're very concerned about the increase in levels of obesity in the borough. You can see again that that's intimately tied up with deprivation. Enfield, particularly in north central London and London as a whole, has a particular challenge in this area. And again, it's not improving. It seems to be actually getting slightly worse. And again, it's getting somewhat worse in the bits of the borough which are least well equipped to deal with it. This is the prevalence of childhood obesity by ward. Again, you can see it's slightly more spread out, but essentially it is still concentrated in the most deprived parts of the borough. Again, this is getting worse, and it's something which is storing up significant problems for the future. It's also an area now where we have significant, trying to think of the right word, political and identity sensibilities around this as well. And again, it's an area which is going to cause huge problems later on. Smoking, Glenn Stewart, who is our Deputy Director of Public Health, he can't be here today. He's in the middle of ramming through our new smoking prevention strategy in Enfield. And as it hasn't quite reached the end of its approval process, I can't go into full details of this. There is some good news in Enfield. Our smoking prevalence rates fell between 2015 and 2018 in adults. And there's reasonable evidence that smoking take-up and persistence in younger people is falling away. And that's partially because of the development of vaping. And I know there's some controversy around vaping, but vaping is the best thing in terms of getting people off smoking that's ever been invented. But smoking in London Borough of Enfield is the 4th highest in London. We think there's probably 400 smoking related deaths a year in London Borough of Enfield, and that's deaths which you can pretty clearly link to smoking. There's probably a lot more. Something which Glenn found out, which actually boggled my mind, was that the financial cost for a 20-a-day habit is now £400 a month for one person. And as I mentioned, the smoke-free plan is working its way through its approval process. So I'll come back to it later on. Vaccinations, something we've obviously been very, very concerned about for the last 2.5 years. And this again shows that the areas of the borough which have significant deprivation, both financially and in terms of health inequalities, are the areas which tended not to take up the vaccinations when they're offered. And this is for the COVID-19 vaccine. Now, I can understand, I really can understand that people will be concerned about what was clearly a brand new vaccine for a novel virus and was developed very quickly and apparently deployed very quickly. I can understand that, but we tend to see this pattern in terms of all vaccinations, not just the coronavirus vaccine. We tend to see this pattern in when we're offering the influenza vaccination, and we kind of tend to see this pattern as well in terms of uptake of officer screening. So it's an interesting phenomenon. And I think on one level, I think us public health people, we were expecting, I think, especially with this novel virus that caused so many problems, when the vaccines became available, people would simply take them up. They would simply have the vaccines. And I wonder if our messaging there really does need a complete reappraisal, because I'm not sure we were as successful as we should have been. There's some further information, some further quite useful granular information about those who take up the vaccination. And you can see that there are very significant and stark differences between ethnic groups. In Enfield, those who are taking up the vaccine, you can see that people who identify as white British or white Irish tend to take up the vaccine to the level of 80–85%. The most significant uptake was among people of Asian Indian background, 86%. And then for people with Black Caribbean and Black African background, it goes down to the mid and high 50s. Very, very significant differences in take up. And again, this is not just something we find with the coronavirus vaccinations. It's something we find in other vaccinations like influenza. You're obviously all aware of the fact there's been a significant campaign recently to improve the uptake of polio vaccination, not just in Enfield, but across London as a whole. And we are seeing exactly the same issues with people bringing forward their children to have the polio vaccine. If there is an identified deficit in the vaccination take up, it's very concerning. Your priorities in terms of our public health priorities in terms of obesity, healthy weight, smoking cessation, vaccination, that they're the things we're very concerned about, because failures in those areas are going to lead to problems stacking up in the future. My particular thing, it tends to be sort of vaccinations, because we're probably going to be entering a world where more vaccinations are going to be offered. The vast majority of people in the UK, adults, I mean, once they've finished their childhood and adolescent vaccination campaigns, they don't need to engage in vaccinations unless they work with older people or they work with vulnerable people, or they choose to have vaccinations before going on holiday. I think it's very likely that with the development of new vaccinations involving memory RNA technology and also emerging infectious disease threats, vaccinations are going to become much more of a common thing. And clearly, based on our experience around coronavirus, we're not doing very well. Things that we're quite concerned about as well, the digital poverty issue. A lot of healthcare requires access to digital devices these days. I think those of us who sit in the public sector, and we've seen a very stark illustration of that a few minutes ago, tend to assume that just because it works on our laptop, it'll work on somebody else's. Access to healthcare these days can be made a lot easier by use of digital technology. That tends to be, if you are, to use a phrase, a digital native, you have access to a fairly secure connection, and of course your first language is English. We're obviously concerned about air pollution and climate change. There's a lot of work going on in terms of reducing the amount of particulates in London's air. We all know about the ultra-low emission zone inside the North Circular. There are plans to extend that all the way to the edge of London. Getting rid of internal combustion cars will not remove particulate air pollution. The majority of particulate air pollution associated with car use these days comes from brakes and tyres. And that problem actually is slightly worse for electric vehicles. Access to adult health care, services and sport, we're very concerned about that. Food poverty is a thing that seems to be getting worse now because of the cost of living crisis. And the mental health impact of the cost of living crisis we're very concerned about as well. So we've been thinking about that as well. I think that was a very quick helicopter view of things as we see it. Just before we take questions, one of the things that we are just starting early work on is our joint health wellbeing strategy, which in Enfield is going to be somewhat different because it's due for renewal next year. We've already started work on it. It has to reflect the post-COVID reality. It also has to reflect the reality of the way things are being organised along at the NCL level now, at the 5 boroughs level. So that's not going to be a glossy document which you can download as a PDF and read at your leisure. It's much more likely to be a sort of program management tool that'll be subject to regular revisions and possibly needs to be reviewed every 6 months at the Joint Health and Wellbeing Board. So that's me. Debbie, do you want to say anything?
No, well, I think you've really covered everything. But I think also just to add in terms of initiatives that are going on to reducing air pollution and smoking is the school zone area. So blocking off areas around schools that have been proposed so that cars don't come in, reducing air pollution, and also the proposal in the smoke-free plan to cut off smoking around schools and colleges. Some schools have already started with that as well. So I think those are some other additions.
Thank you, both of you, Mark and Debbie-Ann, for that. Those statistics and those maps are so hard hitting. And I was at a meeting yesterday with your colleague Louisa before she went off poorly, and with someone from the Royal Free who gave me some information about the death. There have been some deaths in North Central London. I think some of them may have been Enfield, of very sick children as a result of flu, not being vaccinated against the flu vaccine. So this is like, I mean, you said there were potentially around 400 deaths around smoking related. You know, this is a life and death story we're talking about. It's reality. It's not actually a story. Now, what I just wanted to know before we hand over to well, what are the three things I want to do now? First of all is, could you give us a summary, Mark and Debbie-Ann, about your initiatives? So we've seen the challenges, but I know that you've got some initiatives rolling out or that have rolled out, just so that the people on this call can just have a brief update on that, and then we can evaluate whether or not people have heard about them. That's if there are any initiatives. Then I will get everybody else on the call just to very quickly introduce themselves, and then we'll open up to question answer, challenges, requests for information, whatever it is that the direction of this discussion goes. So over to you two first. What are the initiatives that are currently taking place that align with your priorities?
Debbie, could I ask you very quickly to go through MEC and the social prescribing stuff you're involved with?
Yeah, so with so MEC, Making Every Contact Count, is a behavioural change initiative training program that seeks to improve our health and health behaviours, conversations around our health and health behaviours. It also sort of aims to kind of tackle that bridge of, you know, speaking with or talking down, a non-judgmental approach to speaking about health and health behaviours. And that's a project that we've been working on for some time, but we've launched it within the council and now looking to sort of expand outside and with our partner organisations as well. And with Making Every Contact Count training, it's more about sort of improving those conversations that we have around health and supporting people in challenging health behaviours. So we have like an e-learning program that's available for people to take on, and it's not just for, you know, that power dynamic of, you know, professional versus resident. It's also something that we've been, you know, working around the conversation of it being a peer-to-peer and also colleague sort of intervention as well. With social prescribing, we have, of course, as EVA knows, we have our Youth Alive program, which has been ongoing as well. And that's been led so well by Chris Scott. And so we've been sort of working with young people in encouraging them to improve their mental health and well-being, also through exercise and physical activity, and looking through the local community on initiatives that are available to support those young people. I think a key one with social prescribing is a project that's been going on, which is our violence reduction social prescribing program. And that is one that's been working quite well so far, in that it has seen a reduction in reoffending in young people. So majority of the young people who've been referred, who have had a history of engagement with the criminal justice system, haven't reoffended within a certain period of time. And there's also been, I think, one key thing as well that really struck out to me with the violence reduction program is that there's been a lot of girls, young girls, who've been referred into the program. I think when we think of that violence reduction and violence, we do think of the young males, but it is something that is quite an across the board a risk to all young people. So seeing that engagement with those young girls has been quite positive as well, in reducing reoffending and also getting them involved in their local communities as well. I think these can tackle and address health inequalities, which is some of our priorities that have been mentioned. But with some of the other priorities, the initiatives that have been mentioned, I know I spoke earlier about the smoke-free plan that our Assistant Director of Public Health has been working on, and already 32 schools have been involved in having a smoke-free outside area of the schools. So now it's just working on and proposing that being spread to all schools, and then in turn as well, all colleges as well, to reduce smoking and to basically make smoking obsolete, which is something that he has so brilliantly coined.
Thank you. Can I just clarify? Oh, sorry, Mark, carry on.
No, you go first, Helen. Sorry, I do apologise.
Well, I just wanted to clarify three things. One, the Making Every Contact Count training. Health champions on this call will have done some Making Every Contact Count training as part of the accredited training that they did on joining the Health Champions programme. However, I think that personally, from my own experience, that refreshers about making every contact count are really, really valuable. So this training programme, is that something, you said you've got an e-learning, is that something that Health Champions could access?
Yes,
brilliant. And what I would, the other strand of activity amongst the Health Champions in Enfield that we're working on is increasing dialogue about health literacy amongst their networks. Yeah, I think that's absolutely key. We believe that's absolutely key. And so we would want them to encourage their colleagues to do the Making Every Contact Count. So so maybe we can just take this discussion offline to get the details of that, and then I can share it. That's fantastic. That's really tangible. The social prescribe. Sorry,
we were literally discussing a health literacy presentation or workshop last week, and this has popped up on several times within the council as well. And in terms of the Making Every Contact Count thus far, it's like this online thing, and that's partially a function of the fact that we were forced down that route because of the coronavirus, partially the fact that we didn't really have a huge amount of money. But one of the things we're doing moving forward is actually doing it much more face to face. And I'll come back to that in a minute. It's partially in response to Bernard's question, which I can see, which is strobing here, which needs to be addressed. But we haven't forgotten your question, Bernard. We'll come back to it as soon as we can.
Okay, so that's fantastic. So we want to be part of that. And the theme at the next Enfield Health Champions Network event on Thursday, the 26th of January, is health literacy. So so let's tie all those ends together. The second question was for the Youth Alive programme. Can we, just to clarify for the people on this call, is that can anybody refer young people into that now in Enfield?
Yeah.
Yeah, so I'll share that information, and anybody can refer a young person, and that's just brilliant. And the violence reduction programme, that is all really
and young people can self-refer as well.
Lovely. Okay, thank you. That's the clarification I've got on what you've said, Debbie. Thank you. Joe, is your question about Debbie's
No, I just wondered if we could do a sort of introduction of who's here, because I didn't.
Yeah, that's the next thing, Joe,
Brilliant,
that I'm coming to.
fantastic.
I just wanted to make sure there were no questions about what Debbie had said.
Yeah.
So does anybody else have any questions or clarifications about the things that Debbie has just been speaking about in order to access them? If you have, can you put your hand up? No. Oh, Vicky, yeah.
Do you want me to ask a question now?
Just if you've just got clarification about what Debbie's just been talking about the programmes. So
Well, it's just you mentioned about the violence reduction programme and the fact that you're talking about trying to reduce the smoking around the schools and how effective they are. And you were saying that you were doing that young violent people one for mental health and well-being. But I was thinking about what are we doing other initiatives for general mental health and well-being for, across the ages and
okay.
food poverty and so forth.
Can I come back to that question in a second then, Vicky? Yeah, because that's kind of going broader now. I just wanted some specifics. Yeah. So what I'd like to do next is, as I said earlier, is if the people on the call who haven't introduced themselves yet could just do so. And I'm going to just do it in alphabetical order. If you could just say who you are and what organisation you're from, that would be most helpful. So I've got Bernie first, please.
Yeah, hi. Is the sound okay?
Yes, we can hear you.
Oh, at least one thing works. Reese, Community and Environment Project Office. We set the organisation up in 1996 as a response to Local Agenda 21, and we deal primarily, as you might have guessed, with environmental issues. And of course, health is very closely related to environmental issues. So we've become more and more concerned with personal standards of equality and access to resources as a way of dealing with environmental issues. And health is number one at the moment, clearly, by a long, long way. And that involves, of course, things like finding out communication, which is a two-way process. And I think a lot of work needs to be done to find out. It's not that the people on the eastern side of the borough don't communicate, but why is the communication from the health authorities not getting through to them at the moment? Primary concern.
Okay, we'll come back to your question in a second. I've got somebody called Community. If you could introduce yourself, please.
Well, I think that may be me. That's Kim Thompson. I'm the founder of United We Rise UK.
Hi, Kim.
We're a coaching and mentoring service, advocates of supporting small businesses, improving relationships with parents, children, families. I'm also a health champion. Had some fantastic training from Helen, the EVA system. We introduce establishments to Black-owned businesses, institutions, organisations, and educational establishments by collaborating, promoting and utilising services. And it's been a huge eye opener, because just like was it Bernard was saying, stuff that is happening, some fantastic work happening throughout the service, EVA, and other organisations is not being filtered down to different organisations. So it's really good to get this information, because I filter it down to the vast organisations that I actually deal with, and it's been extremely helpful, because they are now more aware of the services that are available and where other services can pick up the slack. So it's been absolutely fantastic. So I'm glad to be here.
Great, thank you very much, Kim. Ginny, you're next on my list.
Hello, Ginny Landon, Enfield Women's Centre.
Thank you, Ginny.
I was going to elaborate on services if you want me to, but I'm happy.
Well, let's just do the introductions and then we can come back to if that's okay. Thank you, Maria.
Hi, my name is Maria Goddard. I'm an urgent care doctor at the Royal Free, and I have an interest in lifestyle medicine. I'm a physical activity clinical champion for the Office of Health Improvement and Disparities, and I'm an active hospital lead at the Foundation Trust here at the Royal Free, because as we know, physical inactivity is a major problem for health, and physical activity is the best treatment we have to maintain our good health and prevent illness. So we're trying to embed physical activity into North London.
Yes, just no biggie then.
No biggie.
Thank you very much, Joe.
Zoe Clef from Enfield Voluntary Action.
Thank you. The next person is Sadia Ibrahim.
Yeah, can you hear me now?
We can hear you now, yeah.
Hi, my name is Sada Ibrahim, and I'm here representing the Dulmer Family Foundation. We're based in Haringey, and we work with BME families in Haringey and Enfield.
Thank you. And last but not least, oh no, Helen, Saunders, and then Vicky, sorry.
Good morning, everyone. My name's Helen Saunders. I'm in the strategy team at North Mid. A big part of that is about how we increase our contribution to wider health and wellbeing instead of just doing the kind of repair work, if you like, at the hospital. So that's why I'm here.
Thank you. Thank you, Helen. Welcome. And Vicky.
Hi, I'm Vicky, and I'm from Bread and Butter, and we primarily work with all ages in community centres and in schools, addressing what people eat, basically trying to address a healthy lifestyle. We also work with people with isolation issues as well, mental health.
I happen to know, because I've talked to Vicky recently, that at least one life has been saved through her programme. So that's significant immediately due to the mental health challenges, let alone the longer term benefits. So yeah, right. Thank you very much. So Vicky, you have got your hand up. So if you have got a question that you wanted to pose, and then what I'd like to do just to keep it organised is if you could just put your hand up if you want to ask a question or make a comment, an observation, and I'll just take them in the order that they're put up, because I've got that comes up for me. So Vicky, over to you.
So how can I get it down to one question? it's kind of looking, well, obviously we've got guys here on who are working on the strategy for mental health and food poverty, and it's like, what specifically are those interventions at the moment? Because like Helen, I very much agree with sort of prevention as opposed to fixing something later. And we're really making headway with the classes, you know, just focusing on my community classes that I do. Is some people the only time they come out of their house is to come to my class, to our classes, and we teach them about, you know, we get people round the table together and they cook meals together, and we teach them through interactions about a healthier lifestyle. And I know that you can give people a piece of paper or whatever, and they're not going to stop buying the usual things that they buy. They need to be given that opportunity to taste something, to do it themselves, to actually know that, oh yeah, actually I will eat a chickpea, or I will eat some beans or something. And we're now getting quite good links up with social subscribers, but there's, you know, and that's really making some headway. But we've got some learnings there that I'd like to improve on, and I kind of want to know how else we can fill that gap. So what's your thoughts on that? Was that far too much in one go? Sorry.
No, it's not. One of the things about public health that occasionally rightfully gets criticised for is that we're very good at knowing exactly what the problem is, but very rarely at providing effective solutions. Now, in the area of sort of mental health and well-being, we have a very clear sort of intelligence function around this. We provide information to those who do provide care and those who make interventions. And of course, we have a significant commissioning function as well. We're aware of all these initiatives. We do have a significant emotional health and well-being component by making every contact count activity. But we do a lot of work at the various sort of mental health forums around feeding in that. Fundamentally, and I'll come back to that, I'm keenly aware that Bernard's question is still up, I'll come back to the fact that the last sort of 2.5 years, we have been sort of kind of glued to our desk doing other things. One of the few successful things during the coronavirus crisis was the fact that public health people, to an extent like people like me, had to get operational. I couldn't simply describe to a group of social care workers the theory of infection control. I actually had to get out and about and do it. And part of that sort of operational role has now become formalised. And one of my jobs in the council is providing infection control and general public health guidance to adult social care. So the way that public health is going to be carrying on moving forwards is much more of this operational role, much more linking up with groups such as yours, actually being there and listening and suggesting and taking ideas back. We don't have a huge budget outside of our commissioning activities, and I was talking about this to my director last week. What we do offer is people like myself and Debbie-Ann to provide a link up. I think to an extent, the mental health and emotional well-being stuff was put on the back burner a bit during the coronavirus crisis. We were aware, we had done work before the coronavirus crisis on the dangers of isolation and the risks of isolation. You have this sort of oft-repeated statistic that living by yourself is as bad as smoking 10 cigarettes a day. But there was a lot of work done around socialization generally in Enfield before the coronavirus crisis. So we're picking that up again. I'm trying to sort of come up with a nice killer answer, and I can't.
Mm-hmm.
I mean, what we are keenly aware of is the fact that the sort of that these challenges are getting worse at the minute for a variety of reasons, and we'll just keep plugging away at it. I mean, I don't think there's a certainly not a silver bullet, but in terms of public health, we're certainly doing a lot more out there than we used to.
Okay.
I don't think there's one thing that works, and I think this ties in what Bernard was asking earlier on. You said the message is clearly not getting out to the eastern side of the borough. One of the things that was interesting about the polio work I was doing recently was that we know that essentially every single parent and carer in London was contacted about the need for the polio updates, and the language aspect of that was well and truly dealt with. I think the messages are getting out, the messages are not being acted on, and we're not completely clear for the reasons for that. And as I said, that's not just around vaccinations, that's around things like screening, and I think it's around things like mental health and well-being as well. And as a service, we have to be a lot more, again, I'm trying to structure of words, much more culturally appropriate, much more culturally aware. And as I said, I was shocked by certain things that went on during the coronavirus pandemic. Bit of self-disclosure, but my wife is of South Asian heritage, and I was on the phone to my in-laws in South Asia, pleading with them to have the coronavirus jabs. And some of the reasons why they were not were an education to me. And that's someone that's been working in public health for a decade, someone that worked in healthcare for the best part of 3 decades before that. Why was this thing a surprise to me? So we have to learn from this experience. It's not just about vaccinations. Sorry, I was in a conversation with the team that are behind the hubs in Enfield. Sorry, Debbie, this is the thing I need to talk to you about later in the week. I've not had this over to you, and they are certainly about us doing a lot more work. I mean, to give an example, one of the things that's always we're keenly aware of is hypertension. Is undetected hypertension is a very good way of finding yourself very ill very quickly because there aren't any symptoms. So why is it that people can't monitor their blood pressure and exactly as easily as they monitor their weight? Well, we don't have enough of these blood pressure gadgets lying around. So we're going to get some of those and we're just going to lend them out from libraries and we're going to provide them to hubs and so on and so forth. But then what happens after that? Now, someone's detected to have high blood pressure, what happens? How do you get that processed by the GP? How do you encourage compliance with the antihypertensive? And there's massive cultural issues around that as well. Massive cultural issues around that as well. And we barely moved on that. And one of the things that I have been tapped on the shoulder and told in no uncertain terms by the newly appointed Director of Adult Social Care in Enfield is that he expects to see public health making a contribution to reducing health and social care costs. So I think it all ties in with this, and we can't do that unless we're out and about and actually listening and acting on what we're being told. And I think that's equally true of mental health and physical health.
Thank you. Thank you.
But
I think
Helen, you and I were talking about this about 4 years ago before the coronavirus crisis came in, and it's always difficult to go from having these great ideas. But I think the coronavirus crisis, one of the things it showed absolutely clearly, it showed in absolutely harsh relief, was that certain people with underlying health problems are much more vulnerable to these events. Much more vulnerable, whether it's hypertension, whether it's obesity, whether it's a chronic breathing problem, whether it's whatever, they're much more vulnerable. And that will be true of future threats as well. And you were speaking about the apparent death of children from influenza, and it's I can't say for certain that the vaccination would have saved that child, but it's probably the one thing that would make a difference, especially when you've got RSV floating around as well. And RSV is going up again, I notice.
RSV?
You go down a couple.
Respiratory.
Sorry, respiratory syncytial virus. I do apologise. I'm very into 3-letter acronyms. They should be stamped out.
Makes it much easier to move on, doesn't it? So I think what we're talking about here is that some of the people on this call can offer some insight and some solutions in some areas, but of course they're not going to be able to provide that solution in all of the areas. So maybe the value is in making the connections between those of us on the call today and from the voluntary sector and those from the statutory sector, whereby if you can make a couple of connections here today where you continue a conversation about the way the voluntary sector person you're speaking to does see that change is happening in the area that they work in, then maybe that could be scaled up. Maybe there's some learning. And I think the really important thing that's coming across to me, Mark, is from your own self-disclosure, is that sometimes we hear things, we know things, but we don't necessarily realise them. And then they flash up in front of us and we think, why didn't I know that? And it's so simple. It might not be simple to address because barriers are complex, even if they are present as simple, but it's that we need to unpick. What I'd like to do, because there are no answers up, Dan, welcome, by the way, from the Carers Centre. Can I just ask Bernie if you could just, because you were talking about communications, Bernie, and you've been within the voluntary sector for many years, longer than me in Enfield, and I just would be interested in just hearing a little bit more about the points that you've put in the chat and the points you've made so far, if that's okay.
Yes, certainly. Look, primarily, almost all of the engagement I've had in the borough is trying to follow up regeneration programs and recycling programs, and doing that with European money or government money or local or support from the local authority. And in all of those, it was a driven agenda. We had a series of targets to meet, and our job was to go out and try to meet them in order to justify the receipt of the grants and the expenditure. And we were always caught up in this dilemma. In order to be effective, we had to have time to listen. In order to meet the financial targets, there was no time to do anything other than just get on with it, not really knowing what was the right way to go about it. So it was a bit hit and miss. When we succeeded, it was very, very lucky. And it was a very frustrating exercise because so many times you'd come to the end of the program with a sense of incompletion. There simply hadn't been enough time to sit down and talk to people, or not talk to them, listen to them and find out what was their resistance. Why, for example, don't people recycle? Why don't they listen to advice about smoking? What is their resistance to taking a vaccination? And all of these are fundamental and sometimes very culturally deeply embedded. And we didn't have the chance to go and find out why. But now it seems to me that there is the evidence there that shows that this activity is definitely going to be needed in future. So we ought to spend a bit more time concentrating on that. And if it means leaving aside some of the targets imposed from above and saying, look, we're not going to make any progress on these until we get out there and start listening to what people's concerns are, then I think we have to say that and be very clear about what we're going to do. And a lot of the training needs, I think, to be around listening and not so much about presenting.
And do you have, thank you, Bernie, and do you have any ideas about what has worked in the odd occasions that you've had the opportunity to do that rather than just deliver?
Yes, certainly. There have been a number of conferences which have been held over the years when people have a chance to come along and talk in small groups. I've actually done a significant amount of facilitation training, where the whole purpose is to allow people the time and space to speak in their own language, in their own words, expressing their own concerns, and making sure that everything you hear is recorded and presented and is not lost. There are ways to do this. And it's a departure from the normal kind of meeting where three people who seem to know sit at the front and everyone else has to wait their turn to speak. And I think that kind of meeting is well past its usefulness. And we need to start thinking more seriously about what kinds of meetings work and how do we do facilitation to make sure we get that information and learn from it.
Well, that's a very practical solution, which I would see would be actually quite straightforward to implement if we've got events that, or I mean, you were talking, Mark, about, I know it's slightly different, but the joint health and wellbeing strategy and maybe consultation that's going to go on around that. So Bernie's comments actually are very pertinent, aren't they?
The thing is, you have to bring in people who know about facilitation.
Yes.
I know a lot of people who run meetings nowadays call themselves facilitators, and they spend most of their time standing at the front, mouthing off, but they haven't even taken the trouble to sit in front of a video and record themselves, so they don't even know what they sound like. We need people who are able to get the best out of the meeting by allowing maximum participation. That is a definite skill, one that needs practice, one that needs awareness and attention. And I don't think yet we've got enough people around who know how to do that. I can find people who can do the training so that people could benefit from it, and I can find people who can run the meetings. And as to getting people to meetings, you just invite them along to talk about things that are close to their heart, and they will come.
So Bernie, outside of this meeting, can I ask you, can we have a chat about this and you can share those resources with me and I'll share it with, or we can have a, however anybody wants to set that up. But I mean, I personally would be very interested to follow up those two suggestions you've made. People you know who can do this type of facilitation and training that can be offered.
Yes,
so
certainly.
Can we do that?
I'm more than happy, either in person or online, because my movements over the next 3 months are going to be quite complex and busy, and I won't be in the UK for the whole of that time, but I'm always available online.
Yeah, well, I will follow this up straight away after today's meeting, so I'll try and pin you down.
Yeah, don't do it on Teams, please.
No. I'll make a commitment to try out Telegram, and maybe if I keep Mark and Joe and Debbie-Ann and Helen Saunders in the loop there, that might be something that is of value to you. Mark has put his email in the chat, and I had already shared his email with you in the.
I'm sorry to go on so long about it.
No, it's absolutely crucial.
You can obviously hear passion. That's actually it's just frustrating sitting in a meeting where nothing's going on.
Absolutely.
So that's actually my nhs.net email, which is reasonably secure as well. Yeah, I haven't actually done any presentation training for a long time. I'm acutely conscious of the fact that I probably am the guy at the front of the meeting who waves his arms around and speaks a lot. Debbie-Ann will confirm that.
Sometimes we need presentations because of the data, and today's presentation I think was absolutely brilliant. So Bernie, Mark has offered to answer your question in the chat about the deaths by email. Is that okay?
Yeah, that's fine.
Yeah, okay. So you if you will contact him, and I will also share the email addresses of the people on this call today. Can I ask if anybody else wanted to make an observation or ask a question? I think what we have identified, though, because Kim also commented on this when she introduced herself, is that communication challenges are key. There is, as you've said, Mark, Debbie-Ann, there are initiatives. There is a lot of information in other languages and information in different formats. So what we have got are challenges around the way people assimilate information and what motivates them to act. And so I'll come to you in a second, Vicky. And something that I worked on last year, which was a pre-diabetes programme with a health and wellbeing coach was where we used the EMIS system, which is the system that's used in Enfield through the GP practices, to text message people that had been identified. Now, okay, these people had already been identified as being pre-diabetes, so if you like, they're the known unwell or potentially unwell. So the challenge still remains around the unknowns, but text messaging was the most successful tool we found, and repeat text messaging was not being a nuisance but a reminder. Then we had some data around how many text messages people received before they responded. But if we think about ourselves when we get contacted about something we don't want to do, or it's not a priority for us because it's uncomfortable. I'm thinking of myself here with the bowel screening programme. It's sometimes we're all human, we're all the same. We need prompting, and we need to be spoken to in a way that appeals to us or motivates us, and that's the $1 million question. So thank you, Sadia. We realise you have to go. Thank you. She's left. Okay. Sorry, Ginny. We have found that not all speakers of other languages read in those languages. Now that's a good point. How do you suggest, Ginny, that we... sorry, Ginny, before I come to that, I did say I'd just take Vicky's comment. Vicky, can I just take your hand, please?
Yeah, let me just lower it for you. Yeah, I was just going back to Mark, really, when I'd asked the sort of previous question, obviously focusing more around food, and you were saying there's not much budget outside the commissioning budget, but is there a sort of strategy to actually get people out to do classes to learn about healthier eating and to address food poverty?
There is a food poverty strategy around, actually, which I've seen in draft form, and there is actually an anti-poverty strategy in the council. I'll have to get back to you on that because that's not something I specifically deal with. I mean, yeah, I will do that thing.
Okay.
Okay. Because on that point, Vicky, on that point, Mark, Vicky used to sit on, back in several years ago, on the early iteration of the local authorities food poverty and healthy eating working groups. So yeah, so Vicky's got quite a bit of kind of background with working with the statute with your team. Yeah. Bernie has just made a point about, we've only got a few minutes left, is there anything else urgent that needs to be covered? Well, I'm going to come to Ginny because I think Ginny's point was very pertinent. Could you just expand a bit more, Ginny? And then Joe.
Okay. I think what we do, I mean, one of the things we run here is a counselling service, and we are constantly recruiting counsellors who speak other languages. Sometimes we're more successful in the variety. Sometimes we might find we have 3 Bangladeshi speakers and nothing else. And then we have a lot of Eastern European speakers, nothing else. But what we think, I mean, that's for the counselling, which is a specific issue. But generally what we feel is that if champions could be trained up on these issues from within the host communities, there would be more that trust that was being discussed earlier. And people will be more likely to come along and listen. I did a lot of stuff during the lockdown, and I remember going to meetings, obviously online. That was a good girl. The GLA held some really, really intense discussions, and it was quite interesting that people are more likely to listen to somebody who looks like them and sounds like them. And the last thing they need is another white grey hair telling them what to do with their lives. Seriously,
that's really interesting.
It's important to get them their own champions. You know, the message isn't about which one of us is doing the most or the best. It's about how we all reach the most or the best.
Thank you, Ginny. And we have actually got some discussion ongoing at the moment about having a cohort of health ambassadors, just so that they're distinct from people who have done the RSPH training and work or volunteer for a voluntary sector organisation. So if it's okay, I've made a note and we will pick up with you on that, just to see how you see something like that working.
Yeah, because
great. Thank you, Joe.
Yeah, so I just wanted to remind people that because funding was mentioned, we've still got for health messaging through the Trusted Voices programme at Enfield Voluntary Action. The large grants, that's no longer available because those you needed to have submitted. That was a two-stage process, but there's still some £500 grants available for health messaging, and the deadline for that is the 5th of December. So and that's for community groups with communities that have a lower than average uptake to the COVID vaccine, to be able to do some health messaging on any topic. It doesn't have to be just COVID. So if you haven't already looked at those, I think we've done quite a lot of information about those, but if you haven't, then please get in contact with EVA. It's on our website, or get in contact with us.
And I've put it into the chat. The link is in the chat.
Brilliant.
Yeah.
Thank you. Thanks.
Yeah. Okay, well, we are out of time. Does anyone have anything else that they would like us to consider, so that I can follow that? I'll put that in the notes into the meeting and tie Debbie and Mark down.
Can I just quickly ask about that trusted voice one? Because I thought that was all to do with, because we didn't apply for that, because it was all to do about spreading messages about vaccinations. But you're saying it's any health message?
No, it's not. It's not about vaccinations. It's about health messaging. It's just that the criteria means you've got to be working with communities that have a lower than average vaccination uptake. So if you wanted to apply for £500 to do something to do with your communications, then have a look at that.
Okay.
But it's got to be specifically looking at those communities rather than a sort of general thing. So
okay, thank you.
no problem.
Am I right in saying, Joe, that getting in touch with Fred would be the first point?
Yeah, get in touch with Fred. Have a look at our website at the which Helen put in the chat, and have a discussion with us, because we're happy to go through, obviously to discuss it with you before you apply, because we don't want to waste anybody's time.
Sure. So
the Asian community, for example, have a higher than average population. So anyone from those communities, we're just telling don't apply, because it's not appropriate.
Fair enough. Okay.
Well, I'd like to thank everyone for taking part today. I think we've actually talked about some of the key issues, which are to do with communication and listening. So hopefully we can take forward some of that discussion in the best way. I mean, this was an open discussion, meant to create an opportunity for further discussion. So let's just pick that up. I will create a mailing list for everybody who was on the call, just so that we can connect with each other if we want to. But I will also then share this recording with the health champions more broadly. Joe, you've got your hand up.
Oh yeah, sorry. I know we're coming to the end. Are you available for a bit longer, Mark, for another question, or do you need to sort of rush off now? Have you got another meeting?
I can hang on.
Okay, sorry. I just wanted. I was just interested. Is there any work being done on whether around around people, the health implications of people being in unheated homes? Is there anything being done around that? Because that's something I'd be quite interested in finding out more about.
There kind of is. We have like a safeguard. I think you're probably aware there's a safeguarding group. So there's a cost of living group that's been set up by the safeguarding lead at Enfield, which is involved in that. The former Public Health England and the UK Health Security Agency has picked up this, and their standard sort of cold weather advice hasn't particularly changed. But there's a lot of evidence that if you are in a room or in a house that's actually at a sustained temperature below 18 degrees Celsius, then things will start to go awry. And that's across most populations and ages and people with underlying conditions. It's quite interesting. So it's not so much cold weather as cooler conditions.
Right.
And that 18 degrees Celsius thing is pretty much the tipping point for somebody dressed in normal clothing with inactive people. And one of the things we've done at home, bizarrely, is actually we've got our thermostat set at 18 degrees Celsius now. And you notice the difference when it goes below 18, you notice. Essentially, once it goes below an internal temperature of 18, you start to see admissions for things like exacerbations of chronic obstructive pulmonary disorder picking up. You see things like emergency admissions for even strokes and heart attacks going up because the core blood pressure's gone up. And you will start to see insidious hypothermia coming on slowly but surely, because the core temperature will start to go down very slowly, especially if you're not having hot drinks, especially if you're not having a reasonably balanced diet. So it's that core thing. So that advice you can find, and that's kind of common sense stuff. Unfortunately, with the cost of living crisis, I think those are exactly the conditions we're going to start to see. The UK Health Security Agency and the Met Office are now jointly sending out twice weekly sort of temperature forecasts. And if you go to either the Met Office or UK Health Security Agency sites, you can sign up to be mailed about those. The last one came out yesterday. In London and the southeast, they're now looking at a 10% chance of an extreme cold weather warning going out, I think the week starting the 20th of December. So thus far, for about a month from now, it's looking as though we're not going to get really cold weather, but they are stating that we are going to start to see normal seasonal weather for late November, early December, which is going to cause us problems as well. We've been very lucky, well, kind of lucky, that we've had these very unseasonable temperatures in October and early November, but the temperatures are going to start to come down now. But that 18 degrees Celsius thing, that's the thing to worry about. Right, once it creeps below that. But if you can sustain that, if you layer up to, I don't know to what extent, and move around a bit. But of course, people don't always do that. They can't always do that.
So the key things there, Mark, are, just to clarify for this conversation, are layering up, warm drinks, move around, get some physical exercise, and eat sensibly. Yeah.
And of course, sorry, and the last thing, I can tend to go on about this, and I know it's a bit medical model, but comply with the medical instructions given to you by your general practitioner. If you've been prescribed the sort of nominal source of medications that older people tend to have, which includes aspirin, if you've been prescribed your blood pressure tablets, if you've been prescribed anything else, then keep up with those. And if you need help to continue with those prescriptions, keep up with that. Most older people don't or shouldn't be paying anything for their prescriptions. And I've reached a milestone today. From now on, I haven't got to pay for my prescriptions.
Oh, happy birthday! It's your birthday today.
Don't want to talk about it.
Oh dear, well, happy birthday, Mark. Thank you for being here on your birthday. If we'd have known, we'd have had a little cake and a candle.
No.
Well, thank you for sharing that with us.
Yeah, but that compliance thing, that's a really important point. I mean, there's lots of people don't. They you know, it's such a massively important thing for maintaining healthy into older age. I'm not medicalizing people. I'm saying that if the doctors have good reason to prescribe you these things, it's the one thing that's kept me out of hospital for the last 10 years since my heart surgery. So, I mean, yeah.
And I think this is where the making every contact count thing comes back,
yes,
isn't it? Is that if we all know to ask the obvious questions, like, are you, just of anybody that we know, are you, you know, I know the advice is keep the person warm, not the home, but that's a little bit different. But the thing is if we ask that question, are you still taking your meds? Oh no, I felt too cold to whatever to go out. Well, let's see so we can get them to, you know, there are lots and lots of ways that we as communities can help address challenges before they become crises. Yeah, that's really useful information. I might come back to you, Mark, with the notes of this session for the links.
But that ties in with Debbie-Ann's suggestion to me that we start picking up on medical literacy. Absolutely right.
Medical literacy on top of health literacy, as well as health literacy. Yeah. No, these I think we've got plenty of things to take forward for further discussion. Jo, did you have anything else you wanted to ask?
No, that's interesting. So sort of, if I wanted any further information on that, who I mean, I might send you an email.
Jo, if you do that, could you copy me in, because then we will, if any links to other information, we will then make sure get circulated with the notes to this meeting.
Yeah, Brilliant,
Yeah,
brilliant. We'd like to do
really.
some more work around that. That's all. So
Thank you. Well, today we found this really useful. Thank you everybody who's still here for coming. Mark has already shared his email with you, so and I will be sharing the communication information. And yeah, maybe we'll be holding another one of these if we can in the new year, in the spring. So or if anything serious needs to be addressed, maybe we'll hold on sooner. But the next Health Champions and Community Leaders Network meeting is the 26th of January, online at the moment, although we'd like to do it in person at some point. So any I mean, there's a lot of time between now and then, so any priorities that emerge we can plan to feature at that meeting too.
And
right.
we've got the cost of living, the Enfield Mental Health Network on the 29th of November and the Cost of Living Crisis Network on the 13th of December. So just dates for your diary for those.
I'll put information about those two in the notes that go out with this recording.
Brilliant.
Thank you.
All right,
Okay.
thank you. Thanks a lot then.
Thank
Thank you everyone. Thank you Debbie-Ann.
Thank you, Mark. Really
Thank you.
appreciate your time.
Really appreciate it. Thank you. Bye-bye.
Bye.